Merci beaucoup à tout le monde pour cet hommage à Pauline qui le mérite bien. Après les controverses, les guidelines, le temps est venu des consensus. Et le premier orateur est notre ami kabnick qui va nous parler de l'indication, non-indication et mauvaise indication du traitement des varices des membres inférieurs. Cher Lowell.
Merci beaucoup. In honor of Pauline. Indications, non-indications, and bad indications. I call it the good, the bad, the ugly. My disclosures. So how important are guidelines? We've talked about that before, but it's important to repeat. And we all understand what guidelines are, but what's the purpose of surgical guidelines? So let us ask artificial intelligence, because maybe I'm not smart enough to tell you. But if we look at it, it's pretty much there to say, provide standardized evidence-based recommendations for performing surgical procedures safely and effectively, developed by expert panels and professional organizations. But remind you that guidelines are formed by experts, but it depends on what group of experts are talking about the guidelines and who is involved in it. So really it's about enhancing patient safety, ensuring evidence-based practice, promoting consistency and quality, supporting clinical decision-making, education and training, and optimizing resource use. So we know about the guidelines, and we know that the European Society of Vascular Surgery in 2022, under the leadership of Marianne, came out with specifics in terms of the great saphenous vein, in terms of what device you should use, and they're pretty much all of them, but they grade still thermal as the gold standard back then. And then the question about using, combining phlebectomy or sclerotherapy along with truncal ablation, that's a shared decision-making process. However, in the United States, we're more like one and done. So we want to do it and get it done with. And there are some papers out there that suggest that the quality of life may be better, but there are also some papers saying that we're doing unnecessary procedures. The same thing with the small saphenous vein. There's no difference there. And then when we look at the anterior saphenous vein, which we talked ad nauseum, there is some decision-making there. But I think as we go forward, certainly the anterior saphenous, the posterior saphenous vein, all are truncal veins, and they all have issues, maybe not to the same extent as a great saphenous vein, but they are all part of our problems with venous disease. In 2022 and 2023, the Americans came out with their guidelines, and they were pretty much similar to the European guidelines. But more importantly, a group of us got together and looked at appropriate use criteria, or choosing wisely. And what happened? Well, the reason it happened was because even though there are guidelines out there, we looked at what was happening in the United States, and if you can see, if you can see that general surgery was involved in 14% of phlebology, vascular surgery 29%, cardiology involved in 21%, but then there was a whole mixture of different specialists involved. And then if you look at the growth rate in vascular surgery as opposed to cardiology, you can see that it was amazing. And this was published in the New York Times. So what is surgical appropriate use criteria? Well, if we look at it in 2020, again, a group of us got together and looked at this 119 scenarios with different cases. And so what is appropriate use criteria? Well, very simply, if I asked AI, it specifies when it is appropriate to perform a medical procedure or service. An appropriate procedure is one for which the expected health benefits exceed the expected health risks by a wide margin. Ideally, appropriate use criteria are evidence-based, but in the absence of sufficient evidence, may be derived from a consensus of experts. So the appropriate use criteria aims to reduce the overuse of venous interventions, identify areas of venous treatment that need more investigation, and provide clarity on how to manage venous conditions. So how is this different from guidelines? Guidelines are based on evidence documents. Excuse me for 1 minute. I'm having emotions from our last. So, thank you. So if we look at appropriate use criteria, it's structured around specific clinical scenarios encountered in daily practice and correlates to guidelines and evidence. Appropriate use criteria offers targeted decision-making guidance on whether specific interventions are appropriate for individual patients in particular contexts. It was developed by a group in UCLA, which is University of California, Los Angeles, the appropriateness methods, and uses a Delphi method. You're going to ask me what the Delphi method is. So what is the Delphi method? The Delphi method is a structured communication technique used to achieve consensus among a panel of experts. And I can go in ad nauseum in this, but I'm not going to. Delphi method allows for evidence-based, expert-informed guidance that clinicians can use to make decisions on specific procedures or treatments. It's particularly valuable for complex or evolving areas where direct evidence may be limited or clinical judgment is crucial. So the process involves the clinical scenarios, the SEEP classification, plus or minus symptoms, and the anatomic extent. And as I said, there are 119 scenarios, and I'm not going to go through all of them because then I would be here for hours. And they were rated on a scale of 1 to 9. So 7, 8, and 9 were appropriate. Treatment is generally acceptable and reasonable approach for the indication, and treatment is likely to improve the patient's health outcomes or survival. 4, 5, and 6 may be appropriate. Treatment may be acceptable or reasonable approach for the indication, or treatment may improve the patient's health outcomes or survival, or more research or patient information is necessary to classify the appropriateness of the indication. Rarely appropriate, 2 and 3, treatment is not a generally acceptable or reasonable approach for the indication, and treatment lacks clear benefit, risk advantage, and treatment is rarely effective for the indication. And 1 is never appropriate. So let's test you with some examples. Symptomatic patient with varicose veins, edema judged to result from venous disease, skin and/or subcutaneous changes, healed or active ulcer, C2 through C6, and whose great saphenous vein demonstrated axial reflux, with or without saphofemoral junction reflux. So the reason I bring that up is in the United States, our insurance companies say that you need to have saphofemoral junctional reflux. But I submit to you that that is probably wrong, and there are some papers to indicate that. So what would we do? The management, ablation of the great saphenous vein, is that appropriate? Inappropriate. How many people believe it's appropriate? How many people believe it's inappropriate? No. Then we better go back to school if it's inappropriate. So the consensus was appropriate, and the commentary on this was several randomized controlled trials indicate that the treating of symptomatic saphenous reflux is safe and effective. We all know that, so I'm going to move on. Symptomatic patients with skin or subcutaneous changes, healed or active ulcers, C4 through 6, and who has segmental GSV reflux below the knee, directed to the affected area. Management consideration, ablation of the below-knee great saphenous vein. Appropriate or inappropriate? Appropriate? Rarely appropriate? Not appropriate. Appropriate. Although clinical data are limited, treatment below the knee reflux seems to benefit those with advanced CVI. So this is what we're talking about in terms of guidelines. There are really no guidelines to suggest this, so then we go into consensus. Symptomatic patients with edema C3 judged to be due to below-knee GSV disease. Appropriate? Inappropriate? Management consideration of ablation below the knee. Appropriate? Rarely appropriate? Inappropriate? Not appropriate? I'm going to go to the moderators. Appropriate for treatment below the knee for C3. Rarely appropriate? Inappropriate. So it may be appropriate. And the commentary was, edema has a variety of potential causes unrelated to venous pathology, undergoing the importance of clinical judgment in the decision whether to treat C3 disease. And I think we all appreciate that. So let's look at the summary of pertinent superficial agreements. So the appropriate use criteria for chronic lower extremity venous disease, and this was published, and there's a pocket guideline. So let's look at this again. So yesterday I went through incompetent perforators and anterior saphenous, and I'll go through it again. But now we're going to talk about GSV. So great saphenous vein was a SEEP classification of 2 through 6, positive axial reflux, positive FSFJ reflux. Appropriate, maybe appropriate, rarely appropriate. Well, we all agree it's probably appropriate. GSV, SEEP 4 to 6, segmental reflux below the knee involving affected area. Appropriate? Maybe appropriate, rarely appropriate. GSV SEEP 3, segmental reflux below the knee, other etiology to rule out. Appropriate? Maybe appropriate, rarely appropriate. So if you have C3 disease and segmental reflux, could there be other etiologies to rule out? And I think that's what we're trying to say. So it's maybe rarely appropriate to treat those vessels below the knee, and we should rule out other disease. Small saphenous, SEEP 2 through 6, plus reflux to the involved area. I think we'll all agree that that's appropriate, right? Appropriate? Who thinks it's inappropriate? Small saphenous connects to the GSV, SEEP 4 through 6, reflux to the involved area. Should we treat the small saphenous vein? Remember that there connects to the GSV and SEEP 4 through 6. Positive reflux to the involved area. Appropriate? Maybe inappropriate? Rarely appropriate. Anterior saphenous vein, SEEP 2 through 4 through 6, plus reflux to the involved area. Now, we talked about that yesterday. And so, what is your opinion? To treat the ASV with reflux? Appropriate? Inappropriate? So the ASV was SEEP 3 plus reflux to the involved area. Appropriate? Maybe appropriate. Rarely appropriate. ASV, no reflux, plus GSV reflux. We know this one. Appropriate? Okay. And Tobias Hirsch is not in the audience? Okay. May be appropriate? Rarely appropriate. Therapeutic ablation of asymptomatic disease and visible veins, C1 and 2. Appropriate? May be appropriate? Rarely appropriate. Bingo. So no reflux, never appropriate. All right, let's look at incompetent perforators, and I'll speed this up a little bit. Incompetent perforators we talked about yesterday, pathological. So these are ones that have 3.5 millimeters, symptomatic, and directed toward the affected area, and they're all C4 through 6. So do you treat an incompetent perforator with that? I think we'll all agree that it's appropriate. Incompetent perforators, again, pathological, and directed toward the area, C3. Appropriate? May be appropriate. Rarely appropriate. So pathological perforator, again, directed toward the affected area, C1 or 2. Appropriate? Interesting. May be appropriate. Rarely appropriate. So I can tell you that the new guidelines from the SVS and the AVF say that if you have recurrent disease and it's related to a perforator, C1 or 2, or C2 disease, you should treat that. So at this point in time, we said it was rarely appropriate, but remember, these came out in 2020, and we started the process in 2019. So the guidelines have been updated, and it'd be interesting to see another consensus on that one. When we look at an incompetent perforator, but it's not incompetent, it's a regular, that's asymptomatic, C1 and 2, we know where that's going. Treatment of non-truncal varicose veins with or without telangiectasia by sclerotherapy, phlebectomy, powered phlebectomy, a symptomatic patient with varicose veins, C2 to C6. Should we treat that? Non-truncal varicose veins. Appropriate? Providing care for varicose veins on an unablated, providing care for varicose veins on an ablated saphenous vein, same time or staged. Appropriate? Referral to a patient, referring of a patient to another provider for treatment of varicose veins after you've done an ablated saphenous vein. In other words, you want to do the ablation, but you refer the patient for sclerotherapy or phlebectomy. Appropriate? May be appropriate. Rarely appropriate. And what do you think the U.S. answered? I don't think it's appropriate, but back in those days, there were interventionalists that were not surgically trained or even trained in phlebology that would do this, and they would, we suggest to refer the patient if they don't have the technical skills to do sclerotherapy or phlebectomy for the patient's sake. Making no provisions for care of the disease varicose vein. In other words, you just do the ablation, forget about it. We know that that's rarely appropriate. Are your surgical indications appropriate? And I leave you with this closing slide. Thank you very much.